Good evening, one and all. I warmly welcome you to our 15th CellTalk webinar. In today's session, Mr. Abhijit Chavan will be presenting research titled Caste, Religion, and Mental Health in India. Abhijit is working as a junior economist at Renix Life Sciences. His tasks include collecting data on socioeconomic variables, politics, GDP, and healthcare data of the state, while also reviewing the literature to analyze this data for writing research papers for journal publications. Abhijit is pursuing his BS in Economic Sciences from the Indian Institute of Science Education and Research in Bhopal. Before joining Renix, he worked as a political research analyst at EDG Research in Hyderabad. At Renix, he has been able to understand the process of writing research papers and further aims to pursue research in macroeconomics and political economics. So, without further ado, I now warmly welcome Abhijit to take the floor.
Thank you, Aditi, for the introduction. I will be presenting on caste, religion, and mental health in India by Ashish Gupta and Danny Coffey. The journal title is Population Research and Policy Review. Its impact factor is 2.329. Year of publication is 2020. This research has an impact on mental health, caste, and religion. As we know, a large multidisciplinary literature in socio-epidemiology, public health, and medical sociology has been concerned with documenting and understanding disparities in health by race, ethnicity, gender, socioeconomic status, and caste. Researchers studying the US have quantified difference in large number of health outcomes by racial and ethnic groups. The study investigated population-level disparities in self-reported anxiety and depression among adults in India by caste and religion. General background is that mental health, in contrast, is widely recognized to be under-research related to its disease burden in low and middle-income societies. Although prior research has shown that in India, caste, religion play an important role in many other health outcomes, including infantility, childhood, and the use of health services. There are three forms of social inequality that may shape mental health in India. This study focuses on two major divisions, caste and religion. The paper documents and analyzes gaps in this self-reported mental health interest between first, higher caste Hindus, which are dominant social groups, and second, the scheduled caste Hindus, sometimes called as untouchables or Dalits. They are the marginalized group which comprises approximately of 17% of total India's population. This study also studies gaps in self-reported mental health cases between higher caste Hindus and the Muslims. Muslims are a religious minority who constitute of around 14 to 20% of India's population. There are many forms of social inequality that may shape mental health in India. This study focuses on two major divisions, caste and religion. A system of social stratification with endogamous marriage, hereditary social status, divides Indians into a large number of groups and subs called jatis, each occupying varying level of ritual purity, privilege, and social status. The objective of this research is to find answers to the question, that is, are there disparities in self-reported mental health indicators between Muslims and higher caste Hindus and between scheduled caste and higher caste Hindus? Second, what is the magnitude of these disparities? And third, to what extent can they be explained by disparities in socioeconomic status of the caste or the religion? Examining these disparities is important for several reasons. First, the marginalized group that study, that is scheduled caste and Muslims, numbers roughly around 200 million and 172 million respectively. Together, they constitute a population greater than that of USA. Second, documenting these disparities in mental health contributes to an ongoing conversation about the extent and consequences of social disadvantages and discrimination in India. Methodologies used. Paper analyzes the World Health Organization SAGE survey of global aging and adult health. which the data was collected in India during 2007 to 2008. Stage surveys adult health, which with a focus older adults and is unique among large-scale population surveys in India because it asks questions about mental health as well as about the physical health. Stage collect data of adult population aged between 18 and above in 6 states. Assam, the states are Assam, Karnataka, Maharashtra, Rajasthan, Uttar Pradesh, and West Bengal. These states were selected among Indian states with population of more than 5 million based on their geographic region, the level of economic and human development. States use a multi-stage process to select a respondent in each state, which are in rural areas, a stratified random sample of villages was selected based on village population size with 8 households selected from each village. In urban areas, a stratified random sample of city wards was selected based on ward population size. Within selected wards, two census enumeration blocks were further selected from which 33 households were selected. However, due to small sample size, they do not include people from scheduled tribes in analysis. Scheduled tribes are also called as Adivasis, like scheduled caste and Muslim. Scheduled tribes are marginalized and often discriminated against. Uh, Here, stage demographic data do not distinguish among the three broad subgroups within higher caste Hindus, that is, other backward classes, forward classes, and Brahmins. They use responses to two general questions, simple worded questions as about self-reported mental health as the outcomes of interest. Sage asked respondent the following questions. Overall, in the last 30 days, how much of the problem did you have with feeling sad, low, or depressed? They can answer in the following ways like none, mild, moderate, severe, or extreme. The next question was overall in the last 30 days, how much of the problem did you have with worry or anxiety? And they can answer in the same way, that is none, mild, moderate, severe, or extreme. The independent variables they use in this analysis are age, sex of the respondent, household asset, own, education, per capita log expenditure, rural residence, state. Here, they asked how large are the gaps in self-reported mental health, and can the gaps between scheduled caste and higher caste Hindus and between Muslims and higher caste be explained by differences in their socio-economic status? To answer this question, two complementary empirical strategies were used. First, they use a non-parametric reweighting standardization technique to generate counterfactual distribution of health outcomes among scheduled caste and Muslim. These distributions tell us what the mental health outcomes of two marginalized groups would look like if they had the same distribution of educational attainment and asset wealth as higher caste Hindus. Second, they use non-parametric order logic regression to show that scheduled caste and must have worse mental health after controlling for socioeconomic status differences. The reason as follows that this table shows the proportion of people in each social group who reported having mild, moderate, severe, or extreme problems with depression and anxiety. Among the three social groups, we study about 43% reported experience sadness or depression in the last month, while 52% said that they experienced an anxiety. For both outcomes, scheduled caste and Muslim respondent had worse health than higher caste Hindu respondent. About 41% of higher caste Hindus respondent responded 46% of scheduled caste respondent and 51% of them respondent reported being mildly moderate, severely or extremely depressed in the last month. Slightly less than half of higher caste Hindus respondent, that is 57% of scheduled caste respondent and 60% of Muslim respondent reported facing an anxiety in the last. Table also reports summary statistics for independent variables and in the analysis. Used in the analysis, it also shows that scheduled caste and Muslims are poorer and have less education than higher caste Hindus. Scheduled castes are also more likely to live in rural areas than higher caste Hindus, while Muslims are as likely to live in the urban areas as higher caste Hindus. In this table, the leftmost bar of figure shows distribution of self-reported depression among disadvantaged groups. This distribution show that higher caste Hindus are more likely than both Dalits and Muslim to report better mental health responses. The rightmost bar of the figures plot distribution of self-reported mental health that are re-weighted using the non-parametric approach. The re-weighted distribution represent counterfactual distribution of mental health outcomes that answer the question: what would the mental health outcomes of Muslims or scheduled caste look like if they had the same distribution of assets and educational attainment as higher caste Hindus? The re-weighted distribution, the right side figure bar shows that the re-weighted distribution are closer to the distribution of the mental health outcomes among higher caste Hindus than the unweighted distribution. But for most outcomes, there is nevertheless a still visible mental health gap. This figure shows distribution of self-depression among the anxiety among the disadvantaged group. This also results in the same way. The study of health, the study of health disparities in USA has access to benefited data set which provide information not only on mental health outcomes, social group membership, socioeconomic status, but also on experiences of discrimination. The extent to which discrimination is internalized stressors, experiences of violent trauma, childhood health, and socioeconomic status, neighborhood level variables, and more recently clinical measures of mental health. If we are to learn exactly how caste and religion shape mental health in outcomes in India, such variables need to be added to the existing health service and new service will need to be filled in. The conclusion here is that this research provides the first population level evidence that scheduled caste and Muslims have worse self-reported mental health than higher caste Hindus. In most cases, these gaps remain even after accounting for the fact that scheduled caste and Muslims have less education and own fewer assets than higher caste Hindus. Their result, however, suggests that merely distributing wealth and even helping scheduled caste or Muslims get more education may not close the gap in mental health. This may be because discrimination against scheduled castes is still widespread even through a set of discriminatory practices known collectively as untouchability have been criminalized since 1950s. This law go largely unenforced. Survey suggests that large section of people still openly admit engaging in this form of discrimination, and some goes for Muslim that they are often victims of politically motivated violence in India. This study will contribute to broader efforts to draw attention to need for research and policy to address social inequality in India. Further, it will study the relationship among discrimination, prejudice, and mental health in context of social inequality and material disadvantages in India, which help in forming social policy in India. It will also help to initiate data collection of scheduled tribes and will be useful for researchers to investigate mental health disparities between scheduled tribes and other groups. Thank you. You can find me at abhijit@renix.org. Next presentation will be delivered by Ishita Narvekar on association of multidimensional poverty, dementia in adults aged 50 years or older in South Africa by Jean Franco Rani et al. It will be on 28th of September. Thank you.
Thank you so much, Abhijit. That was truly a very refreshing and educational talk. I am sure we've all had a lot of takeaways from this webinar. I will now open the floor to the audience for any questions, concerns, or opinions that they may have for Abhijit. So first of all, Shaheen has two questions. Her first question is, what is logit regression?
Just a second. Basically, I haven't studied the logic tech equation, but it followed this equation by which we can find the relationship between the scheduled caste Muslims and the higher caste Hindus.
And Shaheen has one more question, and she asks, what is non-parametric weighting standardization technique?
The same goes with here, that I have not to study these equations, but yeah, they give the relationship between the same variables.
Okay, so I hope that answers your question, Shaheen. If you want to discuss anything further, you can do it now. Okay, so Vijay has a question. He asks, is there any effect on positive discrimination measures taken by the government for benefit of scheduled caste to beneficiaries of government schemes and concessions among scheduled classes improve their mental health?
As of now, in this study, there is no as such benefits by the government schemes provided government, because still there are discrimination happening to the scheduled caste and Muslim peoples in comparatively in the rural areas as compared to the urban areas.
Okay, I hope that answers your question, Vijay. Nupur has a question. She asks, if wealth and education are not the differentiating factors, what is the most differentiation factor apart from wealth and
Sorry,
education?
can you repeat again?
Sure. If wealth and education are not the differentiating factors, what are the most important differentiation factors apart from wealth and education?
Okay. So apart from wealth and education, the differentiating factor is the how this marginalized group are being treated in the society. So let's in rural areas, it mostly happens that the marginalized group are being seated down as compared to the higher caste people. So how they are treated in the society is also one of the factor apart from wealth and education.
I hope that answers your question, Nupur. So I don't see any more questions or comments in the chat box, and nor do I see them in the question answer panel. So with this, I will be closing this webinar, and I would like to again thank Abhijit for this amazing talk. So in closing this webinar, I would also like to inform the audience that the next CellTalk webinar will be held on the 28th of September 2022, and Ms. Ishita Narvekar will be presenting on the topic Association of Multidimensional Poverty with Dementia in Adults aged 50 years or older in South Africa. Again, with this, I would like to thank you for your presence in today's CellTalk webinar and hope to see you this time next week. And I wish you a very happy day ahead.